Hello, I'm Latea, and this is my partner, Rabia. Today, we're excited to share our research on the MAGI algorithm for personalized citalopram response prediction. We've been working on this temporal analysis of medical history events as part of our HAP 786 course here at George Mason University. Let me start by setting the stage. Depression affects about 7% of US adults every year, and that's a huge burden, both personally and economically. But here's the challenge that really motivated our research. Up to 50% of patients don't respond to their first SSRI treatment, like citalopram. So we've asked ourselves, what if we could predict who's likely to respond before they even start treatment? That's where AI comes in. We use the MAGI knowledge base, which has data from over 36,000 patients, to analyze some pretty specific medical history events. We focused on three seemingly unrelated things: cornea thickness tests, cysts near the tailbone, and anesthesia procedures. I know it sounds random, but stick with us. There's a method to this madness.
Thanks, Lataya. So, our main goal was pretty straightforward. Can we predict whether a patient with these three specific medical events would respond to citalopram? Our approach involved diving deep into the MAGI knowledge based contingency tables, analyzing not just whether these events happen, but when they happen relative to each other. We use recursive estimation and logistic regression to crunch the numbers. The ultimate goal is to give clinicians better tools for choosing the right antidepressant from the start. Let's talk numbers. We analyzed 36,312 patients who had at least one of our four key events. And yes, we're counting the citalopram response as an event here. Looking at the prevalence, we found some interesting patterns. About 31% of patients showed a positive response to citalopram. That's actually pretty good for real world data. Anesthesia procedures were fairly common at 14%, while cysts showed up in about 4% of patients. But here is what really stood out. Cornea thickness tests were super rare, only 0.27% of patients. That's just 97 people out of our entire cohort. This rarity actually becomes important later when we talk about the strength of associations.
Now, let's get into the nitty gritty of how we actually did this analysis. We used the MAGI knowledge base, which is essentially a massive contingency table dataset. Our approach had four main steps. First, we established temporal order, basically figuring out what happened and when. We compared how often each medical event occurred before the target outcome versus after it. Second and third, we calculated direct effects, both for when these events occurred and when they didn't occur. This is crucial because sometimes the absence of something is just as informative as its presence. Finally, we use logistic regression to estimate coefficients that would let us predict response probability. You can see our SQL query on the right. We use this mediation formula where D equals T minus lambda times indirect effects, all divided by 1 minus lambda. It sounds complex, but it's basically untangling direct versus indirect relationships. This slide shows one of our key findings: the temporal sequence of events. We found that cysts typically occur first, followed by cornea tests, then anesthesia, and finally the citalopram response. The evidence is pretty compelling. Cis preceded anesthesia in 34 cases versus only 20 cases, where anesthesia came first. Cornea tests preceded anesthesia 7 times versus 6. And crucially, anesthesia preceded response 212 times versus 154. This temporal ordering is super important because it helps establish causality. We can be more confident that these medical events are actually influencing treatment response rather than the other way around.
Here is where things get really interesting. When we were calculating the direct effects of having these medical conditions, we found some surprising results. Cornea thickness tests had the strongest association, an 11.9% direct effect on response. That means having a cornea test was associated with about a 12% change in response probability. Cis and anesthesia both showed moderate effects around 7.3 to 7.4%. What is fascinating is that even though cornea tests were the rarest events in our dataset, they showed the strongest predictive power. This suggests there might be some underlying biological or clinical connection we haven't fully understood yet. But here is the plot twist, and honestly, this was our most striking finding. When patients didn't have these medical events, their response rates were much higher. No anesthesia, 34.6% response rate. No cyst, 36% response rate. No cornea test, 36.1% response rate. And this tells us that the absence of these conditions significantly increases the likelihood of responding to citalopram. It is like these medical events are red flags that might indicate treatment resistance.
When we put it all together, in our logistic regression model, we got these coefficients. The intercept is negative 0.861, and all our predictors have negative coefficients. Cornea at negative 1.425, cyst at negative 1.98, and anesthesia at negative 1.887. Now here's where our story gets really interesting. For a patient who has had all 3 of these medical events, our model predicts only a 0.21% probability of responding to citalopram. That's incredibly low. But here's the kicker. The actual patient case we were modeling reportedly did improve on citalopram. So we have this interesting contradiction between what our data-driven model predicts and what actually happened clinically. This suggests that there are probably important clinical or psychosocial factors that aren't captured in our current model. Maybe things like patient motivation, social support, concurrent therapies, or genetic factors that we just don't have the data on yet. Let me summarize our main takeaways. We established a clear temporal sequence: cyst, then cornea tests, then anesthesia, then treatment response. The direct effects showed cornea tests as the strongest predictor at nearly 12%, while cyst and anesthesia were both around 7%. But the really compelling finding was that not having these conditions was associated with much higher response rates, around 35%. Our prediction model gave a very low probability for treatment success when all 3 conditions were present, despite the actual patient reporting improvement. This highlights both the potential and the limitations of our current approach.
So, what does this all mean? Our AI driven analysis using the Maggie knowledge base definitely provides some valuable insights into citalopram response prediction. But the low predicted probability for our test case suggests we are missing important pieces of the puzzle. Our recommendation is that AI predictions like ours should be integrated with traditional clinical assessments, not replace them. Think of this as one more tool in the clinician's toolkit. For future work, we really need to incorporate individual level data and additional variables, things like genetic markers, concurrent medications, severity scores, and psychosocial factors to make these models more accurate and clinically useful. And finally, here are our key references. We built on foundational work in depression treatment research and mediation analysis. Thank you for your attention. We're happy to take any question.